Hi, my name is Denise Bowen. I'm an assistant professor at the PA program at Western Michigan University. I serve on the Inclusion and Diversity Council for the Physician Assistant Education Association with your program director, Dr. Abercrombie. And she's kindly invited me to prepare this lecture for you about a special population about whom I'm really passionate. I graduated from PA school 27 years ago, and I got my first job in family practice in Madison, Wisconsin. I started doing some volunteer work in a free clinic in Madison, and I was really challenged by working with underserved and immigrant populations. After several years, I went to work in the Guatemalan refugee camps in Mexico and also in some villages in Guatemala, and I trained lay health promoters to provide primary care. Well, after that experience, when I returned, I accepted a job in a migrant health center serving migrant farm workers from Mexico. The health center eventually became a year-round full-service community health center, but I'd found my niche working with the migrant farm workers, and I did that for the next 15 years. I had the privilege of providing care in the clinic as well as working in a mobile medical van at migrant Head Start centers and with lay health promoters in the outreach program. So a little bit about migrant. Each year, there's almost 2 million seasonal farm workers in nearly every region of the country, and they provide the manual labor necessary to grow and harvest the fruits and vegetables that we eat. And with every visit to the supermarket, we're unknowingly confronted with the realities of the agricultural system in this country. Migrant farm workers are an invisible population in our society. However, without them, we'd be forced to pay very high prices for our produce. Today, I'm going to give you an introduction to this special population. I'll put migrant health in a historical context, and then we'll talk about the demographics and migration patterns overall. Then I'll specifically talk a little bit about Alabama and the East Coast stream. Then I'll introduce you to the health issues that migrant farm workers face before talking about the challenges involved in delivering health care to this population. So in the 1850s, there was an advent of technological innovation in agriculture. There was advances in crop production, machinery, transportation, refrigeration, and all of that increased the demand for a migratory seasonal labor force. Well, in the 1930s, when overfarming and poor soil management and severe drought caused those big dust storms in the Great Plains states, farmers from the Dust Bowl lost their livelihood, and they became the new migrants, and they traveled to California and other regions in search of work. Well, in 1942, with the onset of World War II, there became some pretty big labor shortages in the agricultural fields. And so U.S. and Mexico signed what came to be known as the Bracero Agreement. So Mexican citizens were recruited to alleviate those labor shortages, and hundreds and thousands of impoverished Mexicans migrated annually on temporary work visas to work as braceros. And the Bracero program continued until 1964. Well, in 1952, the H-2 program was developed to provide visas for agricultural workers who were being hired by growers in the U.S. Many growers hired undocumented workers, though, because of the limited number of visas available and because of flaws in the program. So by 1982, the problem had gotten significant, and so there was an Immigration Reform and Control Act that gave amnesty to the undocumented workers in the U.S. and then penalized growers for hiring them for the first time. Well, out of that rose the need for a new program. So by 1986, the guest worker program was revised and is now known as the H-2A program. It only brings in fewer than 100,000 workers annually, and so if you look at the overall numbers population-wise of farm workers in the U.S., it's not a very big portion. Now, the history of migrant health legislation is also kind of interesting. The Migrant Health Act was signed into law on September 25th of 1962 by President John Kennedy, and it established the authorization for delivery of primary and supplemental health services to migrant farm workers. In 1983, we started seeing some legislation that provided some protection for the workers. And so the farm workers' rights were established for the first time in the Migrant and Seasonal Agricultural Workers Protection Act. And then in 1987, the Field Sanitation Standard was passed with the help of OSHA. And so now drinking water, toilets, hand washing facilities are required for the workers. In 1992, the Worker Protection Standard was passed by the EPA to protect farm workers from pesticides. All those have had a big impact on the provision of migrant health. Now, the Migrant Health Program is currently funded under the Consolidated Health Care Act of 1996, and it's administered by the Office of Minority and Special Populations in the Bureau of Primary Health Care and the Health Resources and Service Administration of the Department of Health and Human Services. So in addition to these federally funded programs, there's a network of non-governmental organizations that are involved in promoting farm worker health. These are just some of them. I've got some links for you later at the end so that you can explore that a little more if you're interested. Let's take a short look at farm worker demographics. Now, this study quoted or says that there's 1 to 2.5 million farm workers in the United States, but there's some recent estimates that put the number of farm workers, including their families, at closer to 3 million, and about maybe a little over 1/3 of those are actual workers. Now, the majority are men, about 78%, and half of them are between the ages of 20 and 34. There's actually another number that was interesting, that 500,000 children work in agriculture. Now, looking a little bit more at the demographics, the majority of farm workers are Spanish speaking. Okay, so 71% have the dominant language as Spanish, and not coincidentally, 71% are foreign born. 68% of those are coming from Mexico and about 3% from Central America. So on the East Coast, there's also some groups of farm workers from Haiti. Some estimates say that there's about 50% of farm workers that are undocumented. Most of the migrant farm workers who are foreign born are coming from landless, rural, poor families. They're poorly educated. The average is an 8th grade education, but many more are totally illiterate. A lot of the farm workers have limited English proficiency, and some actually have limited Spanish proficiency, which we'll talk a little bit more about other languages. So most farm workers have come to the U.S. to make a better life for themselves and their families, and the story about their lives prior to coming to the U.S. is often overlooked. The lack of opportunity in Mexico has driven the exodus to the U.S. in order for them to be able to survive and for their families to survive in Mexico. In addition to the poverty they endured in their homeland, the farm workers are a marginalized population in the United States. They occupy one of the lowest rungs on the socioeconomic ladder. The vast majority earn less than $20,800 a year, despite the hard work that they do and the long hours that they work. So where are they going? The vast majority are working in California, Texas, and Florida. We have significant numbers up in my neck of the woods in Michigan as well. Talk a little bit about migration patterns. It's definitely based on circumstance, so it can vary depending on a family's circumstances and the availability of work. Trends in agricultural practices, weather, crop successes or failures all will have an impact. There's a few different patterns, though, that are fairly common. The nomadic pattern is followed when workers travel to wherever there's work. They usually don't know when or where the next move will be. The workers following this pattern are generally foreign-born. They're single young men working in the U.S. and sending money home to their countries of origin. Workers following the restricted circuit pattern will follow crops in one area close to home, and typically a couple adults from the household move to work but come home frequently. Point-to-point migrants will move away from their home base for extended periods of time, and they often go back to the same location for multiple years. Often a whole family travels together. These migrants make up parts of the stream. There are three major streams of migration in the U.S., and they have their sources in California, Texas, and Florida. Now, many of the workers have their home base in those states and migrate to the same farms every year for generations. Now, many of those folks in those streams are not foreign-born. They are Mexican Americans who have lived in those areas for many generations. They'll sometimes will cross over or do some restricted circuit travel depending on the success of the harvest and availability of work. If work is available year-round, many of these families will settle out upstream or change their home base to the upward parts of the stream. You can see in Michigan we have people coming from Texas and from Florida from both parts of those two streams. We refer to the one on the East Coast as the East Coast Stream, and then the West Coast Stream, and then the middle one is called the Midwest Stream. In recent years, we've seen an increase in the number of H-2A workers coming in groups of contracted laborers from Mexico. There are fewer families traveling together and more single men. And we're also seeing more folks settling out in rural communities upstream and continuing to work as seasonal farm workers without migrating. We're seeing, because of the difficulties with border crossings, we're seeing that foreign-born immigrants are not returning to Mexico yearly as they have in the past. So thus they'll settle in the winter in areas where they might find other types of work. We're also seeing people coming from different parts of Mexico than before. There are more indigenous Mexicans migrating to the U.S. than ever before. We're also seeing that they're going to areas that have not traditionally hired migrant labor in the past. This means there's less housing available and it's not always provided by the growers. A word about the indigenous Mexican populations. There are four major groups coming mainly from southern Mexico. They are the Nahuatls, the Mayan, the Mixtecas, and the Zapotecas. And they speak different languages. Those are the four major languages, but there's some others as well. These groups are marginalized and often discriminated in Mexico, and they're coming from some of the poorest and most isolated rural communities in their country. They rarely have more than a third or fourth or maybe fifth grade education, and they often only speak rudimentary Spanish. Many of the women actually don't speak Spanish at all and only speak in their indigenous languages. They usually travel together in a real tight-knit community, and they often live together in really extremely crowded conditions. They tend to be given the jobs with the lowest pay and the worst working conditions. From a healthcare viewpoint, it's of note that they have a higher incidence of depression than the non-indigenous Mexican, and they're much more likely to use traditional medicines. This is a chart that's adapted from Seth Holmes' book, Fresh Fruit, Broken Bodies. He's a medical anthropologist who just published this book. I haven't read the whole thing yet, but it looks very interesting. It's about an indigenous group of migrant farm workers. It illustrates the hierarchy on the farms that he's researched. And Anglo-American workers, even if they were teenagers, were given the jobs with the most respect and requiring the least labor. Mexican Americans were also given more supervisory jobs and easier work. The foreign-born Mexicans were lower on the ladder rungs, especially if they were undocumented. However, the indigenous Mexican was the lowest of the low, given the riskiest, hardest jobs with the least amount of pay. All right, let me shift this a little bit and bring this a little closer to home for all of you in Alabama. I did a little research into the migrant patterns and issues in your neck of the woods. I found most of this information in this report that I've sourced here for you. It's from the Florida Association of Community Health Centers, who did a report in June of 2012 about farm workers in Alabama, Florida, Georgia, and Mississippi. So the migration patterns in Alabama, most of them are following the eastern stream that originates in Florida and goes mostly up to the South Atlantic states. there's some crossover there to the Midwest and to the West Coast as well. Alabama's agriculture is predominantly involved in poultry and livestock, but they do have some labor-intensive crops that need migrant farm workers for the harvest, namely strawberries, watermelon, pecans, onions, tomatoes, and Christmas trees. Compare this to Florida, which has almost 75% of their agriculture in labor-intensive crops. They've got like close to 30% in fruits, tree nuts, and berries, another 30% in nursery greenhouses, and another 20% or so in veggies, melons, potatoes, sweet potatoes, etc. So there's a lot more work in Florida than there is in Alabama for migrant farm workers. The peak season in Alabama is between May and July. Some folks might stay through September because there's some work in the mid-season of August to September. And compare this now to Florida, where the peak season is from October to April. So when the workers are finished in Alabama, they would typically move to Florida and work there the rest of the year. Now, we need to talk about some of the anti-immigrant laws in Alabama and in Georgia and South Carolina as well. I don't mean to pick on just you guys. There's been a big effect because of those anti-immigrant laws on migration patterns and the demographics. So you're seeing in your state a decrease in number of workers. There's fewer workers that are migrating for fear of being detained. Those who do migrate are changing paths to avoid traveling through Alabama, Georgia, and South Carolina. As more farm workers choose not to migrate out of Florida, there's an increase in families reported in the Southeast and a decrease in families reported in the Mid-Atlantic region. And organizations in Georgia, Maine, New Jersey, and New York, and some places upstream report that there are an increase in Haitian workers who are documented. Over 80% of health centers surveyed in Florida and Georgia reported that growers were experiencing difficulty in finding workers. There have been reports of field and orchard crops left unharvested due to the lack of workers. Sadly, there's also some reports from Georgia and Alabama that roadblocks have been set between clinic sites that appear to target their patients. The anti-immigrant laws have been cited as one of the top barriers to accessing health care in the East Coast stream. So now we'll focus on some issues related to the health of the migrant farm worker. Thousands of farm workers experience preventable injuries and illnesses annually, even as they bear the burden of the U.S. consumers' groceries on their backs. I like Cesar Chavez's quote here. It's ironic that those who till the soil, cultivate and harvest the fruits, vegetables, and other foods that fill your tables with abundance have nothing left for themselves. Cesar Chavez was an activist in California working for farm worker rights in the 60s. So we'll talk about barriers to healthy lifestyles first. The barriers to good health are really similar to those of any marginalized population, but migrants do have some extra barriers. The overarching barriers to a healthy lifestyle for any immigrant population include the cultural issues of language, health literacy, and differences in models of illness. But add to that the issues faced by any population of low socioeconomic status. Living in poverty means that accessing food and health care is difficult. Inability to pay for services and supplies, and living in substandard housing also all affect individual and community health. But in addition to those barriers, the migrant farm workers also experience social exclusion and isolation. They're often separated from their family and support systems, or they're living in really isolated rural areas. Their jobs are not very secure. They may stay in dangerous or questionable jobs in order to remain employed. Especially if they're undocumented workers, they're afraid of rocking the boat, demanding their rights. So they fear that if they take a day off for health reasons, they'll be fired. And they have no sick leave. Because they're constantly mobile, there's often a discontinuity of care, which we'll talk more about later. Sometimes a barrier to accessing care is just confusion about the U.S. health systems and lack of knowledge about it. And Don't underestimate the effects of racism. Not only does racism form a barrier to care, but the stress it causes can affect individual health. The assessment that was done on the eastern migrant stream showed that the state anti-immigrant laws also affected farm worker health. Migrant health centers reported a decrease in the number of patients seen, more missed appointments, more stress-associated illnesses, and delayed entry into prenatal care, and decreased use of preventive care. Because of the delays in care, they saw more complications of uncontrolled chronic diseases like diabetes and hypertension. They reported that 57% had no health care in the last 2 years. The health centers identified these things as the top barriers to care on the eastern stream. Note that state anti-immigrant laws and fear of deportation are at the top of that list. So let's look at some of the specific health issues faced by the farm worker. Agriculture is a really dangerous occupation. It's ranked in the top 4 most dangerous occupations in the nation. Your risk of dying as a result of your work is 12 times higher for farm workers than in any other population. First, there are injuries related to the machinery and hand tools used. Eye injuries from branches and other foreign bodies, suffocation from silo accidents, And next, the musculoskeletal problems. Falls from ladders, injuries are very common. Other musculoskeletal injuries from repetitive motion and heavy lifting, carrying, reaching. If you're taking care of farm workers, you're going to see a lot of back problems and carpal tunnel syndrome. And you also see a lot of early degenerative joint disease. Weather can be the enemy of the farm worker. In addition to dehydration, the hot weather will bring on heat exhaustion and heat stroke. Exposure to extreme cold can cause frostbite and hypothermia. Being out in the rain and the snow and the humidity will increase the incidence of skin infections from fungus. And of course, there's sun exposure that not only will cause burns, but a higher incidence of skin cancer. And lightning strikes, fairly common in this population. Insect bites, especially in children, can cause really extreme reactions. And poison ivy, I've never seen such severe cases of roost dermatitis as I see in the farm workers. In our orchards in Michigan, there's tons of poison ivy growing around the apple trees, and the farm workers are expected to clear out these weeds growing around the trees, and they often come in looking like this picture. Exposure to dust and pollen, that'll increase the incidence of respiratory illnesses and allergy symptoms. And we see higher incidences of asthma and chronic bronchitis, in addition to things like farmer's lung, hypersensitivity, pneumonitis, and histoplasmosis. There's also a higher incidence of TB. That's mainly attributed to the higher incidence in the home country, but also because of the overcrowded conditions. Another huge risk is pesticide exposure. Pesticide exposure can occur both while the farm worker is on the job and at their home. The migrant housing camps are often adjacent to the fields. I've actually seen airplanes spraying the fields during dinner time, and the drift from that spray covered the entire migrant camp, where children were playing and people were eating, clothes were hanging out to dry. The pesticides contaminate clothing, and that's often carried to their homes, exposing family members. And folks often unknowingly use recycled containers for personal use, and that's a problem. There are pesticide safety regulations that exist, including the Worker Protection Standard, which I referred to earlier, and that says that the field workers have to be trained on pesticide use. And in the Occupation Safety and Health Act, that requires employers with 11 or more employees to provide drinking, toilet, and washing facilities for farm workers while they work in the fields. However, a study conducted in eastern North Carolina polled 300 farm workers regarding pesticide safety and training, and they reported lots of violations of the standards. Now, the primary route of exposure is absorption through the skin. Immediate removal after an exposure to the skin is crucial, to minimize the exposure. And so that's why it's so important to have the hand washing facilities. Dry clothing may decrease the skin exposure, so wearing long sleeves and long pants, etc., and gloves is important. But wet clothing, whether it's from sweat or dew or rain, will all increase the exposure. Now, wearing the same contaminated clothing the next day will re-expose the farm worker to the pesticide. So there's certain clothing that typically is not washed daily, like shoes, gloves, jackets, etc. The next most common route is inhalation of the pesticides from the drift of the spray. And the last route of exposure is through ingestion. This one isn't as likely, but it's typically when old pesticide containers are inadvertently used for drinking water. So that study in North Carolina showed that 75% had water available for hand washing in the fields, but only 44% were provided with soap. 51% were told that when it was safe to enter fields immediately after application of pesticides. Only half were told when pesticides were applied. Only 35% reported being provided with pesticide safety instruction by their supervisor. 28% reported they worked in areas adjacent to fields where pesticides were being applied, thus being exposed to drift. 25% were asked to enter fields before it was safe to do so. 16% worked in fields while pesticides were actually being applied, and only 14% were provided with pesticide safety equipment if they were applying pesticides. So even though we have the worker protection standards, they're often not enforced. Now, another pesticide danger for farm workers is the limited information they're provided about the pesticides they're being exposed to. They're not told what types are being used. They don't have much control over the exposure. They often live in grower-provided housing and don't know the severity of exposure in those dwellings. Another challenge is that growers rarely speak the same language as workers, and so they aren't giving good education on pesticide safety. Now, I don't have time to go over all the symptoms related to pesticide poisoning, but they can range from a contact dermatitis to a real mild systemic symptoms to severe life-threatening illnesses from high doses or some significant problems from chronic persistent exposure. So if you do work with migrant farm workers, you're going to want to educate yourself on the effects of pesticide poisoning. Poor sanitation also increases the farm workers' risk for poor health. There's a higher incidence of infectious disease because of exposures in the field and issues like overcrowding related to substandard housing. For example, intestinal parasites are much more common from drinking contaminated water. Toilet and hand washing facilities in the field are usually moved from spot to spot depending on where the bulk of the workers are working. However, the reality is that the facilities can be miles away from where the workers end up at the end of the day. Some of the migrant camps, these are pictures of migrant camps in Michigan, have been described as Michigan's third world. 98% of Michigan migrant houses that are inspected mid-season did not meet compliance with the standards. Often several families will be assigned to the same trailer or housing unit. In areas where there's no housing provided, temporary farm workers will live in their vehicles or in makeshift shelters. Often in the camps, there's shower facilities and toilets that are in a central location and not in individual units. The next big health issue that I'd like to talk about are mental health concerns. Contributing factors are separation from families, isolation, discrimination, fear, work conditions, but they really are susceptible to problems like anxiety, stress, and depression. A 2008 study in North Carolina revealed that 40% of the farm worker participants reached the threshold for potentially clinically significant depression. In 2001, there was a study in California that showed that 80% of farm worker participants reported needing relief from stress and anxiety. Another report of studies of farm workers along the U.S.-Mexico border found that 41% of participants reported nervios. I'll talk more about that, which is nervousness, basically. 37% reported depression, and 17% reported latidos, or heart palpitations, which were attributed to anxiety. And remember that I mentioned this earlier, that depression symptoms are more prevalent among indigenous Mexican farm workers than in non-indigenous Mexican farm workers. Domestic violence is perceived to be prevalent in migrant communities. Some people attribute this to the machismo culture that we often see in Mexican families, and some attribute it to the stress. There's no good research, but one survey said that 67% of migrant farm worker men identified domestic violence as a big problem. Now, substance abuse is prevalent in the migrant farm worker camps. It's often a way of self-medicating for the stress and anxiety and even the musculoskeletal pain. Payday is not a good time to visit the migrant camps. But interestingly, the frequency of substance abuse is not tied to ethnicity, but it is tied to the type of crop work. Those doing the most difficult, backbreaking labor have the highest risk for substance abuse. There are some barriers to treatment of mental health issues. The traditional values in the Latino culture often create some of those barriers. It's really common for farm worker patients to resist the use of medications and counseling. In one study of 115 participants with depression symptoms, 29 refused treatment, 62 agreed to treatment but didn't keep the appointments for counseling, and only 24 attended more than 4 of the 8 sessions offered. It's not that the counseling doesn't work for this population, because of those 24, the majority did have relief from their symptoms. There are some traditional Mexican folk illnesses that are important to the understanding of mental health among the population. For example, nervios is a set of symptoms that can include worry, jumpiness, irritability, depression, agitation, anxiety, nervousness. Then there's something called ataques de nervios. These are similar to panic attacks, but can also include violent outbursts. And then there's latidos. Latidos are not just, literally I think it would translate as heart palpitations, but they usually connect that symptom with anxiety or stress. Another example of a folk illness related to mental health is susto. It's a condition that can include a lot of different symptoms, like disturbed sleep, depression, gastrointestinal issues, listlessness, and they are brought on by a sudden, frightful event, so something that scared them. The result of that fright is that the soul temporarily leaves the body. There's also the belief that susto can trigger other illnesses. For example, I have many patients who attributed the onset of their diabetes to a susto that was a significant stressor in their life. Well, this makes sense when you think about the effects that stress has physiologically in our bodies, and the research certainly supports showing those links between stress and many chronic diseases. Now, the traditional treatment for susto involves a ceremony in which the body is swept with herbs while prayers are being recited. This is usually done in conjunction with the Western medical treatment that they may have been prescribed. My patients always seem to view Western medicine as complementing their traditional medicine, and so they're very open to having medications prescribed, even if they attribute susto as the cause of their illness. Now, traditional medicine is practiced by the majority of the Mexican population, especially the poor and uninsured and the indigenous populations. Alternative medicine and treatments are often not disclosed to the provider for different reasons. The first most common reason is that the providers aren't asking. Another reason is that they're afraid of being ridiculed for using traditional medicine. So be open to this in order to get that information. Now there's some different type of practitioners of traditional medicine that your farm worker patient might use. If they have musculoskeletal pain or injuries, they might seek out a sobador. Sobadors perform different types of massages and manipulations combined with spirituality. They usually treat soft tissue injuries very effectively with massage, and they will be sought out quite frequently for any musculoskeletal complaints. A hierbero are herbalists, and they use a variety of herbal remedies to treat symptoms. Now, you don't have to go to an herbalist in order to use some of the herbal remedies that are popular with Mexicans. Chamomile is a very important herb. It's called manzanilla in Spanish, and it's very good for its calming effects. Aloe vera is called savila in Spanish, and it's good for bites and rashes. Eucalyptus is a favorite, used for colds and for all kinds of things. Vicks Vapor Rub is a very popular product that is used for lots of rashes and colds. Marigold is called Flor de Muerte. This is more popular with Guatemalans, and it's used for lowering fever. The third type of practitioner is a curandero. A curandero is a combination of the herbalist, the sobador, and the spiritualist, and they use the relationships between illness, healing, and religion. So they have a distinctly spiritual realm to their healing practices. One of the syndromes that may be treated by a curandero is mal de ojo. Mal de ojo is caused by envy, and it may present as a glance of admiration from a person that is inflicted for too long on a weaker person, usually on a child. So basically, if you are admiring an infant, for example, and you're in that position of being stronger than the child, you could be causing mal de ojo. So you can negate this effect by touching the forehead of the child you're admiring. So if you're admiring an infant, please make sure to touch their forehead so you don't give them mal de ojo. Now the symptoms of this include fever, fretfulness, headaches, crying, colicky behavior. And the treatment is to rub an egg over the child's body while reciting a prayer. You can see if the treatment worked by seeing if the egg sinks or floats in a glass of water afterwards. Caída de mollera is another culture-bound syndrome that is characterized by a sunken fontanelle in an infant. We recognize that symptom as indicating dehydration, and indeed Mexicans note that the sunken fontanelle is accompanied by causes of dehydration like fever and vomiting. However, they attribute the caída de mollera to bouncing the baby too roughly or removing the nipple from the baby's mouth too quickly. The treatment involves trying to raise the mollera by pushing on the baby's soft palate or by hanging them upside down. So including education about caída de mollera in your well child care can be done in a respectful way, first acknowledging that it's a real syndrome, but negotiate about your understanding of the cause. I typically find that parents are very receptive to using hydration therapy as a treatment, and you can avoid the harm that might come from hanging them upside down and pushing on their soft palate. One last culture-bound syndrome that I'd like to discuss is empacho. Empacho typically presents as gastrointestinal problems. When patients tell me they think they have empacho, they usually describe symptoms of either dyspepsia or irritable bowel syndrome, and it seems like the etiology they attach to it is pretty appropriate, really. So they'll use some traditional healing for empacho, and they'll also use some lemon, chamomile, soda water, antacids. They're also open to Western medicine to treat empacho. Farm worker health also involves caring for chronic conditions. Often the patients with chronic illness present when they are out of control because of the barriers to access, which we discussed earlier. I've seen patients with hemoglobin A1Cs of 18 and higher. One of the first patients I saw when I started working in migrant care had to have his foot amputated from gangrene. He'd been on medications for diabetes for 10 to 12 years, but no one had ever checked his labs or changed his medication. Because he was usually just passing through, the provider would just give him a refill of the same meds that he was on, which weren't working very well, and tell him to follow up with his primary care provider. I want to mention some of the paradoxes that we see with both Hispanics and immigrants. For many years, scholars and public health officials have known that people with greater income and formal education tend to live longer, have better lives, better health than their counterparts who have less education or less schooling. And that trend holds true wherever researchers look, in poor countries or rich ones in Europe, Asia, the Americas. But there's two notable exceptions that stand out. One is known as the healthy immigrant effect. Looked at as a group, immigrants to countries as diverse as the U.S., Australia, Germany, all live longer than their new native-born neighbors. Yet immigrants also tend to be less well educated and are often more likely to live in poverty in their new countries. The other exception is called the Hispanic paradox, and it's particular to the U.S. In study after study, people of Hispanic descent, especially Mexicans, seem to live longer than non-Hispanic whites, who on the average happen to be richer and better educated. Well, in 2011, the life expectancy at birth in the U.S. was 3 years higher for Hispanics than it was for non-Hispanic whites. And the paradox is real. Data errors cannot explain it, but the cause of it has been a mystery. Now, if we kind of combine the healthy immigrant effect and the Hispanic paradox, we look at something called the immigrant paradox. And it also looks at immigrant groups and their native-born counterparts, and it really seems that the Hispanic origin immigrants are more prone to this paradox. So foreign-born Mexicans who live in the U.S. have better health outcomes than Mexican Americans who have lived their whole life in the United States. So there's lots of reasons to explain this paradox, lots of theories. Some people think that only healthy people are migrating, and so they also think that the data may be skewed because immigrants who became ill may go back to their home countries. Some think that cultural factors account for the difference. Families may be tighter knit and there may be more support. They may have had a better diet and did more exercise in their home countries. Some people feel that smoking explains the paradox. The incidence of smoking in immigrants is significantly lower than in non-immigrants. Now, with more time in the U.S. and across generations, health outcomes of immigrants and their descendants worsen. We see increased levels of hypertension, obesity, diabetes, and other chronic illnesses the longer the immigrants stay in this country. Is it because of adaptation of our unhealthy habits in this country? Food choices, smoking, alcohol use? Children of immigrants typically start off with an advantage. When they're born, they have lower levels of infant mortality, less incidence of low birth weight. But the older they get, we see that the advantage wears off. Children of Latino immigrants seem to be the most susceptible to the development of unhealthy lifestyles leading to obesity, hypertension, and diabetes. So, now you have an idea of the health issues that you'll confront if you're taking care of migrant farm workers. I'd like to spend some time talking about the challenges of delivering health care services to this population. The first challenge is the difference in culture and language. Typically, there's limited bilingual staff available in most clinics. The phone answering services might only be in English. The clinic schedule advertising might be done in English only. Interpreters are often not available. Patient education and prescriptions may only be available in English. So providing the multilingual and multicultural services takes extra care and thought. Recruitment and retention of qualified bilingual and bicultural providers and staff is difficult. Providing relevant training and continuing education to providers and staff is really necessary. The mobility of the population poses a whole new set of issues. We all know how important continuity of care is. Well, barriers mean that farm workers may only seek care when absolutely necessary and when disease is advanced disease and where there are complications. So the problems are that once treatment begins, the patient may move. If they seek care in the next community, they may not recall details of treatments or they may have lost their records. Communication between providers in other states is notoriously difficult. If you've ever sat on the phone for 45 minutes trying to get connected to someone to get some information on a patient from Texas, you'll understand that. Migrant health centers have learned to adapt to these challenges. For example, many centers use portable medical records in which patients can hand carry with them to their next destination, so they could be updated at every visit, or before leaving the area the patient can come in and pick them up. The Migrant Clinicians Network is advocating the use of their Bridge Case Management program to help facilitate care. I'll talk more about this in a minute. Electronic health records are proving to be a help, especially if community and migrant health centers are using the same networks. Some sites are developing telemedicine networks as well to connect providers from different sites when the patient is actually present. Now, there are three basic delivery models. The health center model is where there are standalone clinics. So in places where there's a high population of migrant farm workers that come back year after year, that can justify having a health center just for them. There are voucher program models. These are where patients are provided with vouchers to receive health care in the communities from other private physicians, etc. These are real popular in areas with low density or short seasons. They usually combine a service coordinator or a nurse staff model with some outreach services. The third are mobile service delivery units, which can include medical vans for providing primary care services, or maybe vans equipped with portable dental equipment to provide dental services. I worked on the medical van for Intercare Community Health Work as part of their outreach program for a while. That's the van in the upper left. We went directly to the migrant camps or work sites and provided primary care. We also had a dental van. There are lots of challenges to operating these services. First of all, the demand often exceeds capacity with seasonal fluctuations. So there may be an incredible need for services for 2 or 3 months, and then the need drops to zero when the harvest is finished. There's a need for extended hours so that the farm worker does not have to take off work to receive the needed health care. At some points in the harvest, farm workers are starting before the sun rises and continuing well after sundown 7 days a week. Then it might rain, and then when it rains, they all would like to receive their health care. Appointment schedules are always a challenge. Schedules are often overbooked during peak season, and there may be long waiting times for appointments. No-shows for appointments are common because of unforeseen changes in work schedules due to the weather or harvest needs, transportation problems, or mobility. And then there are cultural differences related to time as well. We jokingly refer to Mexican time when a patient comes 2 to 3 hours early or late for an appointment. Most clinics have a really hard time with integration of walk-in patients into their appointment systems. In reality, those who can operate on a walk-in schedule are able to increase their capacity significantly. Migrant health organizations and clinics have risen to the challenge and have developed some unique delivery methods. Providing needed services on site at migrant education or Head Start facilities or at the farms themselves have helped to improve access to care. Developing outreach services that may include the use of case managers and lay health promoters has also provided access or improved access and delivery of care. Earlier, I alluded to the Bridge program developed with the Migrant Clinicians Network. This program attempts to coordinate care among providers. They provide help with interstate and international referrals and follow-up, so not just limited to the U.S., but also to partnerships with Mexican providers. They will even help to facilitate provision of ancillary services like transportation and home visits. Other case management programs might center around coordinating care with migrant education or migrant Head Start programs. Another solution is the use of promotores de salud, lay health promoters. The promotoras are trained to help get the word out about available healthcare services. They become a liaison between the migrant farm worker population and the migrant health center. For example, they might identify pregnant women in their communities or in their camps and connect them to prenatal care. They also might do blood pressure or diabetes screening and provide health education to their communities. They may assist outreach nurses to facilitate follow-up of patients and home visits. The health promoter model is really popular in Mexico and Central America, so most Mexican immigrants feel really comfortable with them. There are also some cost challenges involved in delivering health care to the migrant farm worker population. Medical costs in general are rising uncontrollably, and the amount of federal monies to support the migrant health center has kind of stagnated. So most employers do not provide any health insurance, and Medicaid is typically only available for the U.S.-born farm worker. Even if they do have insurance or Medicaid, outreach services are not reimbursable. There are lots of resources available for training related to provision of care to this special population. I'd encourage all of you to check out some of these organizations and take a look at the work they're doing. I've got the websites up here for you. So I alluded to Cesar Chavez, who was an activist in the 1960s and 70s who fought for farm worker rights. And I just want to end on the same quote before. It's ironic that those who till the soil cultivate and harvest the fruits, vegetables, and other foods that fill your tables with abundance have nothing left for themselves. Hopefully our efforts to improve the health of the migrant farm worker population will help to change that. I'd like to thank and acknowledge two sources of most of the information I presented in this talk: the National Center for Farm Worker Health and the Florida Association of Community Health Centers. Also, the East Coast Regional Migrant Health Coordinators did an assessment that I referred to quite a bit. So if any of you have any questions for me, I'd be more than happy to answer them. I'm really, truly passionate about migrant health. And if you have any questions or desire to know more, please shoot me an email and I'll be happy to get back to you. I thank you so much for your attention and your interest in this special population. Good luck to all of you, and thank you.